Patient came with a complaint of left shoulder pain radiating into the neck and left arm. She stated that was back earlier this month. That on 3/24, she was lifting a box of frozen food weighing perhaps 10 pounds, started to feel pain in the neck and left shoulder, arm area shortly thereafter. Patient had a previous history to the shoulder and neck in 2021, had a QME in 2022 with future medical care. Since that time, she'd been doing yoga and applying topical creams and been doing well for a while. So got worse. And the question was, is this part and parcel of the old injury, or did a new event occur? Millie, what was your, other than what was provided in that short summary, what would you like to know and what was your thinking on this?
Well, basically, I ask a lot of questions. How is her shoulder doing? Did she have any residual pain? And overall, she was doing pretty well from the time that they had the QME done. She was pretty much able to do her normal job, which she was doing at the time of the recurrence of the pain. She, thought because she was doing well that, the events of her normal job, it was a new injury. And at the time, I didn't have the QME, but she told me that she did have future medical care. So my assumption is that this was more of an exacerbation of pre-existing. She was doing her normal function as far as her job was concerned. Aggravation and exacerbation are really, they're so close that it was, it's hard sometimes for me to figure it out too. But I talked with you, and again, the adjuster, this was late in the evening, so the adjuster wasn't available too. So we took her date that she had the injury to make my note, but my note stated that I think that this is her pre-existing problem exacerbated. And the adjuster agreed to put this under her past injury. So we're using this as a future medical, under her future medical and giving her some treatment, and she's improving, and we've returned her to transitional duty as well.
Good. And that sounded just right. This is a very subjective sort of decision that we make. It's not like getting a CBC and seeing what the hemoglobin is, or getting an x-ray and seeing if there's something out of place. This is one of those situations that's a judgment call on the part of the provider, and we just simply need to use our best judgment about what we think's going on. We gather as much information as we can, and then we make a call. And with every other decision we make, if somebody disagrees, the patient, the carrier, the employer, whomever else, the patient or the carrier / employer can always request a QME, and somebody can gather even more information and make some other decision about it if that's appropriate. But what we do, our role, we just make the best judgment we can. It's a subjective call, and we gather what information we can. Now, there are some measures we can use that will help us. These can be a little bit soft, but if the patient's got problems from a prior injury or illness and has future medical care and has ongoing symptoms, then if there's a need to make a material change in the medication, increasing it, add something new, that may indicate a bona fide change called an aggravation. If we need to make a change in work restrictions that are substantially different, the patient may have permanent work restrictions of some sort, and so if we make some modification in that, if it's a substantial change, that can suggest the possibility of aggravation. If the employer reassigns the person to another job because of this alleged event, that, or an increase in therapy, again, increase in symptoms or change in physical findings. Now, you recall perhaps in this graph that the patient that's got future medical care is the B graph. And so they're going to wax and wane in their symptoms over the course of time. They become PNS at this point in the graph. And then it's kind of a sine wave, irregular sine wave of some days, weeks, or months, the symptoms are worse, and other periods the symptoms are better. So there's going to be this sort of ebb and flow in the patient's findings, and maybe medications, and maybe what they can do on the job. It may be that their ebb and flow occurs, and they get to this point on the graph out in the future, they're they need to limit their lifting or their waist bending or some other thing, and then as their ebb or their flow declines to that point on the graph, then they can do a little bit more. So there is going to be the patient with future medical care, their ability to do their job, their symptoms, how often they take their medication. That's going to change. It's going to fluctuate anyway. But is there a material change that you would visualize as on the C graph? Now they're substantially worse. And so you're listening to the patient, you're gathering that information, and then you're just going to make your best judgment. And if it's your opinion that they're just still down on the B graph, then it's an exacerbation. It's a worsening within the limits or the fluctuations of their pre-existing problem. Or if you determine they're on the C graph and they're the fluctuation is more substantial. So if it's more substantial, however you measure that, you call it an aggravation. And if it seems to be just kind of their waxing and waning of symptoms, you call it an exacerbation. Almost invariably, the employer and the payer would like it to just be an exacerbation, for a variety of reasons. They open a new claim, although this isn't the sort of thing that should be on our minds particularly, but just to understand the motivation of the employer and the payer, when it's a new claim, then of course there's what's called a reserve put on it. Whenever there's a new injury, there's the employer, and this is all in their tables, has a fixed amount of money based upon the injury and the employee's age and some other considerations that's going to be allocated and set aside for care, active care for that patient. And that reserve can be a fairly large amount of money based upon what they think the future of that new injury is going to be. If, however, these are considered to be just part of future medical care, there's no reserve set aside, and so it's less expensive to the carrier in terms of management. Again, that's something that is useful to know, but it's not something that should really influence us. We make our best decision based upon all the information we can gather, and then we proceed with that. So I think the right decision was made in this particular case, and it was considered future medical care. And again, the employee feels differently. They can get a QME, and there's just nothing that we do really that's that's etched in concrete. So you recall the potential indicators of aggravation, exacerbation. Think about the graph, try and mentally figure out where they are in that graph, and then you just come to your best conclusion, which is it's going to be whatever it is. And in the end, it's a subjective provider decision. So you won't be held to anything other than just making your best decision about it, and then see what happens. So good job on that one, Millie.